This is a demonstration of an ab internal canaloplasty using the iTrack new advanced system. This first combination case is actually an ABIC and hydrous. And so first you're going to see us making that paracentesis location. I'm a right-handed surgeon, so mine goes at approximately 3 to 4 o'clock, kind of an angled incision pointed at the trabecular meshwork itself. We're then tilting the head and microscope approximately 20 to 30 degrees. I'm having my assistant throw some viscoelastic on the cornea, and I've already deepened the angle so I can best visualize the trabecular meshwork and canal. And so you see me here inserting the iTrack advanced tip of the cannula through that paracentesis wound. I'm going to come up using the tip of the cannula, and I'm just going to score the trabecular meshwork. My goal here is to score the trabecular meshwork to the point that I can usually see a little bit of white. That stark white color is the actual posterior aspect of the canal itself. Once I see that white background, I know then I have access to the canal. I'm going to slowly insert by rolling forward on the sliding mechanism, and you can see as that tip of that catheter goes around the 360 degrees of the meshwork, it actually depigments the TM. And that just shows that it's expanding the entire canal. And then as I pull back on the injector, I'm going to slowly roll it back, and my assistant is injecting viscoelastic. I want you to watch right there. You're going to see that red area go more pale, kind of whitish, and that's a sign that that viscoelastic is going through the distal collector channels and through the episcleral venous system and blanching all those blood vessels. That is usually a sign of a very good treatment. So that's a nice demonstration. We've gone 360 degrees with the catheter. That canal is now open, so it's extremely easy to slide in something like a hydrous stent. And so you're going to see me go through the exact same incision point. I always want my hydrous, if at all possible, to go in the inferior nasal location. I'm going to put the tip of that injector right up against where I formerly created the goniotomy and just slide that stent right into place. So there you can see the stent went in nicely. We can see all of our eyelets. I advanced it forward a little bit more just to put it exactly where I want it. Now this is going to be a demonstration of a less straightforward case. In this case, it's going to be a more difficult actual goniotomy creation because in the beginning here, I'm not going to position the eye perfectly, and I'm going to end up paying for it a little bit. So I'm creating that same paracentesis wound right here. I'm going to then rotate the head approximately 20 to 30 degrees. My assistant is going to be throwing the viscoelastic on the cornea, like you can see right here. And so what I've done here in the beginning is I haven't rotated it enough, and you can see it almost immediately with the eye. It's not tilted like it normally is when we do these goniotomy views. I'm bringing in the catheter through that para. I'm tilting the eye myself with my hand in the iTrack cannula. I can see a pretty good canal here, and I'm just going to try to score, again, the anterior aspect of that canal to where I can see white. Is that as I'm doing it and relaxing a little bit with my hand, the eye's falling forward. And each time I try to push this catheter forward, you'll watch it dive down instead of going straight forward. And so here you can see it there, it dives down. It has a downward angle, so I know I'm not in the canal. And I'm going to keep trying to score here, but as you can see, my view is slipping. And the reason it's slipping is because I initially didn't put the head in the correct location, and I was originally just pushing with my hand on the catheter. And so now I'm realizing I need to stop trying to fight this. I can make it a lot easier if I just tilt the head a little bit more. And right here is where I'm realizing that. So now I'm going to give the head a much better tilt. I'm going to deepen the canal just to make sure I can get the best, deepen the angle just to make sure I can get the best possible vision. Apply a little bit more viscoelastic. We're going to throw the catheter back in. I have a much better view of the canal, of the angle. The TM's a lot deeper. It's much easier to see. I'm going to create a nice goniotomy now. And instead of the tip of that catheter diving downward, it should go forward. There it is. There's that little white section. And now it's going around. No longer diving down. You can see it going 360 degrees around. That's the really nice thing about these illuminated tips. They show you exactly where you are at all times. That tip is now 360 degrees. As I retract it, my assistant is going to be injecting viscoelastic. My goal is about 35 to 50 clicks of viscoelastic. Again, watch this hyperpigmented area of vessels right underneath my main incision. You're going to watch it blanch out as that catheter comes around. And here we can watch it go from that bright red to a much, much paler red. Again, that's a nice sign that that viscoelastic is going through the entire outflow system. Thanks for taking the time to watch this video.